Next, a call and a plan to reduce the number of routine medical tests and procedures. 9 medical specialty groups say many of these tests are unnecessary, costly, and even risky. Among the group's recommendations, avoid using x-rays for lower back pain in routine cases, limit stress tests or EKGs in annual physicals, cut back on prescribing antibiotics for minor sinus infections, and scale back on treatments even for some cancer patients. According to some estimates, nearly 1/3 of the money spent on U.S. healthcare is devoted to these types of tests, procedures, and visits. You can find the rest of the list on our website. For more on the group's recommendations, we turn to Dr. Glenn Stream, president of the American Academy of Family Physicians, and Dr. Eric Topol, a cardiologist and chief academic officer of the Scripps Health System. Welcome to you both. Dr. Stream, how widespread would you say are the incidents of this over-testing, overuse?
Well, as you described, estimates are somewhere in the 30% up to a full third of the costs of delivering health care to the people in our country are expended on health care testing and treatment that doesn't contribute to their health and well-being.
But don't people expect to get the best tests possible to get to the bottom of their complaints?
Yes, they expect to get the best test, and they should. But sometimes the issue is that more testing and more treatment isn't in their best interest, it doesn't add to their health, and many times actually can adversely affect their health and cause even serious complications.
Dr. Topol, in your practice, how often would you say that you get pressure from patients to prescribe things you wouldn't recommend, and how often is it that doctors are overprescribing?
I think it's very much tipped to the doctors' overprescribing issue, Gwen. I don't think it's too often that patients are demanding or strongly requesting scans and procedures. It's usually the other way around.
So what drives that then? Why would doctors overprescribe? Is it because, I don't know, why would it be?
Well, part of this is knee-jerk. You know, we live in this kind of technocentric world in the medical community, and so it's entrenchment in this. And part of it is this is what makes the reimbursement model, unfortunately, in the United States work, and hospitals and the medical system. This is what drives it.
Well, let me ask you, and then I want to ask Dr. Stream this too. How does a patient know who trusts his or her doctor? How do you know what the best test is? How do you know when someone's saying, go get an EKG, it seems like a good idea, when they really don't need to?
Okay, well, I think the issue there is that we need to individualize things. So, you know, to have these blanket guidelines across these various professional societies, you know, that to try to cut costs and unnecessary things is fine. But each individual needs to be carefully assessed, and that should be a shared decision between the physician and the patient. So, you know, you don't want to see things standardized, because that's in fact what has been largely the problem. Every individual deserves special consideration.
But Dr. Stream, you're my doctor, I trust you implicitly, and you tell me to do something. Am I to say to you, according to your guidelines, am I expected to be, as the patient, empowered to say to you no?
I believe you should be empowered. And I see this effort today, and I applaud the American Board of Internal Medicine Foundation for bringing this group together. It's a shared educational effort to both physicians and patients to have that information, to have good shared decision making, because you should be able to say, if I recommend a particular test or treatment, is that the right thing for you? And what's the chance that that's going to help you? And what's the chance that that might harm you? And you know, I think perhaps the experience is different in different specialties. I as a family physician, I often see patients who ask for specific treatments. Antibiotics for a sinus infection is one of the examples for my academy. Or, you know, I've had terrible back pain for a week. Don't I need an X-ray? And it can be difficult to explain to patients that an X-ray, if they don't have certain warning signs, is not likely to contribute to their treatment, but could involve not just unnecessary expense, but unnecessary X-ray exposure.
What about potentially life-threatening diseases like cancer? Don't you want to take as many tests possible to rule out the possibility, or to catch a cancer early, which is what we've all been told has to happen?
Even in those serious illnesses, and in the cardiology realm, and I'll certainly defer to Dr. Topol as well, but there is certainly such a thing as too much testing. The American College of Cardiology, in their 5 items for this effort, identified those things. So even for someone with established heart disease, what's the interval of time at which they should have certain follow-up tests? Because over-testing and over-treatment can truly be harmful.
Dr. Topol, this is not the first time that the Medical Academy has tried to scale back on testing. Whenever there was a report that comes out about slowing down the number of mammograms, for instance, there's always an outcry. Why would this be different?
Well, you know, this is a long overdue issue. And this is not an emotional thing. This is overuse of testing. Go back, for a second, to something that Dr. Stream was commenting on. In cardiology, all too often, every year, we have nuclear stress tests ordered as a routine knee-jerk thing, and that exposes each individual to a lot of radiation, you know, equivalent to thousands of chest x-rays. And this is just crazy that it's continuing. And it's about time that we saw professional societies like cardiology and these others, you know, start to make a statement that this is not the acceptable norm. It might be right for individual patients, but it shouldn't be for all patients in each of these disciplines.
But I guess my question, Dr. Stream, is why is it that the doctors would pay any more attention to these recommendations than they have to recommendations like this in the past?
Well, I think that the advantage is this concerted effort, not just in one specialty, but these specialties working together. I believe that we have better information available from medical studies just over the last several years that highlight the issue of overtreatment. And it's not intended specifically as a cost-saving effort. It really is truly to use the best care when necessary and avoid treatment and testing that's not helpful. But the consequence will be to save a significant amount of health resources that then can be directed to those people that need those services.
Dr. Topol, what about doctors who worry that if they don't make every available test, that they will be more vulnerable to malpractice claims?
Well, that's a concern, Gwen. It's unfortunately a legitimate one. And that's one of the excuses that's all too commonly used for this over-testing problem, really what could be considered a longstanding epidemic. But I don't think in most cases, unless there's clear-cut justification, that would come into play. I think it's too often used as an excuse to cover things. But, you know, normally it's just, you have this particular condition, I'm going to do these tests or order these procedures or prescriptions, and there's just not enough of this one-to-one matching of what the patient's real needs are with what ought to be done.
Is this one of the conversations that came up in your recommendations, and you're thinking this through in your group, Dr. Stream, that perhaps doctors might resist?
It really wasn't brought up that much in our group, but I think that the reason is that the idea of using this information to enable that shared decision making will enable the patient to feel input and some control over what testing and treatment they have, as opposed to a whatever you think, doc, sort of an approach where then there is second guessing after the fact. I think if patients are given good information, here's their condition, here's an option as far as testing or treatment, here's the benefits and the risks, and you together choose the right treatment.
How do you weigh the benefits and the risks?
Well, I think it's difficult, even for physicians, and when we are patients, and we all are patients at some point in our life, if it's an area outside of your specialty, it's hard to be fully informed. And yet I think it's a responsibility of physicians to do the best they possibly can to explain that risk and benefit to patients about various tests and treatment that are being recommended.
Dr. Topol, is this something which can take hold immediately, or is this something that's going to take a whole change in the way we approach our doctor-patient relationships and our treatment relationships?
I wish it would take place quickly, Gwen, but the reality is that the medical community moves incredibly slow. It's ultra-conservative, resistant to change. So, you know, these things are long overdue. They're in the best interest of patients, and certainly for the addressing the healthcare crisis economic issue. So the problem is there's no enforceability, and so it's unlikely that this will make a substantive change in the short term.
At least not in the short term. Dr. Eric Topol, Dr. Glenn Stream, thank you both very much.
Thank you.